be okay.
My mic is not working.
No. This one.
This one is, do you want to come up here?
Yeah.
Okay.
I think it's working. It's working.
Here, I'll just share with you. That's fine.
Yeah.
We're going to go ahead and get started. I know that the last conversation about labioplasty and genitoplasty is something that we hotly debate amongst ourselves, and it's fascinating, but we're going to go ahead and get started because what's standing between you and lunch is this last presentation. So we want to go ahead and get started. I'd like to introduce my co-moderator, Daniela Ivanova-Panova. She is a new IFA-PAG fellow, and she's president of the Young North Macedonia PAG Society. She's a professor of the medical faculty in OBGYN in Skopje, North Macedonia. And I'd like to introduce, I'm going to go up here now, because I'm bending. Okay. All right. I am bending over, so this is going to be better to do from up here. I'm really excited for this next presentation. I'd like to introduce Nicole Tyson. She is a clinical professor of obstetrics and gynecology and the division chief of pediatric adolescent gynecology at the Lucille Packard Stanford Children's Hospital. She is a world leader in PAG, and she's a member of the FIGO's Contraception Committee, where she's created the FIGO International Adolescent Contraceptive Podcast. She is vice president of the North American Society of Pediatric Adolescent Gynecology, go NASPAG. She is past chair of the American Association of Gynecologic Laparoscopy, that's AAGL, PAG Special Interest Group, which she helped form. And she's a member of special interest groups for the Society of Family Planning and the an Association of Reproductive Health and Medicine. And the reason why I took a little bit extra time to mention all those different societies is that there are so few of us in PAG, and if we don't get out into the other societies and explain who we are and what we do, we'll keep ourselves too small. So part of what we need to do when we advocate in PAG is go out into the other societies and preach the gospel, as we say. Okay, and then I'd also like to introduce Megan Harrison, because they're going to be presenting this first part together. She's associate professor of the University of Ottawa in adolescent medicine and a physician at CHEO in Ottawa. Go Canadians! Dr. Harrison's clinical expertise and research focus on adolescent mothers and their children, pediatric eating disorders, marginalized and high-risk youth, and adolescent and sexual health. She's actively involved in the Canadian Pediatric Society as past president of the Adolescent Health Section, and she's co-chair of the North American Society of Pediatric Adolescent Gynecology Advocacy Committee. And advocacy, you'll hear a little bit more from me on later, is a huge part of what we all can do. Take it away.
Thank you, Judy. Do we still get 15 minutes?
You do.
Thank you. Thank you, everyone. So this will be a little transition from our last talk. This is pretty noisy, but thank you for having us. We're going to be talking about periods and the environmental impact and equity. We have no disclosures. I always like to dive into, talks doing math that I have in my head. So each one of us who has periods will have 450 periods in our lifetime on average. We'll spend 3,500 days on our period. That's 10 years having a period, each one of us with a uterus. And we'll use about 11,000 menstrual products in our lifetime of having periods, which most commonly would be period pads, menstrual pads, feminine hygiene products, all these different names. And just to capture the relevance for all of us individually, at this one moment, there's 800 million people around the globe on their period. So, relatable to all of us.
Thank you, and I want to echo that a little bit here and talk a little bit about the menstrual health around the world. So first, in terms of our disclosures, where I'm certainly not important enough to have any financial disclosures. However, we all have our own biases, so I present this knowing that my bias is that I come from the Canadian context and I work within that context, so I know kind of most about menstrual health in that context. That said, there is some great research going on around the world trying to measure the experience differently. Of course, that's inherent to some biases. It's hard to measure an experience since we're all individuals. And each country has its own challenges and strengths for that matter. This is just a nice overview from an article from 2016, which is a snapshot. It's taken, there's more in the article about different countries around the world, but just in this image, it sort of highlighted a few places. Looking at what women use and people who menstruate, what they use in terms of their hygiene products. Now, important for me to say this isn't what their choice of product might be, it's what is used. So certainly there's not a lot of choice for many people, but what is more commonly used in the United States is a disposable pad, store-bought disposable pad. In Germany, this article would state, maybe my German colleagues can correct me if this is incorrect, but states that about 70% actually are using tampons. In China, 83% disposable store-bought pads. And India, a great proportion using homemade alternatives for their periods. Ethiopia and Kenya as well, homemade alternatives. I'll just speak very briefly about the other parts. It's kind of hard to see on that slide. This also has its challenges in terms of measuring access, since I can tell you from the Canadian context, where I live is south, get my bearings right, is southeast of the country. And my experience is extremely different than an adolescent or an adult with Aboriginal descent living in the First Nations communities in Canada. They'll pay at least triple the price for the same product that I do when I'm further down. So again, there's a lack of access kind of everywhere, and I want to underscore that. But in this image, it talks about lack of access to sanitation facilities, not just products. So less so of an issue in terms of sanitation facilities in the United States and Canada. I'll add myself in there. And the same in Germany, as this would state. In other areas of the world, there's certainly a huge lack of access to sanitation facilities outside the home and inside the home. And all of that, which we'll talk about, can certainly affect the environment. It affects many things, but we only have 11 minutes and counting down, so we'll talk about the environment. The last point that's made on this slide, and I'll just focus your attention on India there at the bottom. It's stating here that 71% of girls and those who menstruate report having no knowledge of menstruation before their first period. So that's talking about sort of the general knowledge. Again, this data is inherently flawed. That happens everywhere around the world, but these are just percentages. It's very, very, very difficult to measure the environmental impact of anything, for that matter, but especially for these products. And I'll take you through this a little bit. I like this cycle. It's very gentle language. It talks about the end of life of a tampon, the end of life of a menstrual pad. So you can walk through this with me. It's very difficult to measure, but in general, the environmental impact is measured by the use of the raw materials, energy and water during the actual manufacturing process, the extraction of those raw materials, material processing, then product manufacturing, and then the distribution, so how these things are distributed and what the impact on the environment is in terms of the distribution. The packaging needs to be considered, the ingredients used in the products themselves, so cottons versus plastics, and then the packaging, which is usually plastics. Now, this is all speaking about those store-bought products. How many products are used and disposed of worldwide? As Nicole so kindly said, we're all, we menstruate for 10 years of our lives straight, so we use a lot of products. And then how these products are disposed of, so that end of life cycle, that's actually a massive part of the environmental impact. Certainly the disposal practices are very different depending on where you live. In some areas, the used products are burnt in certain locations. In other areas, they're used and buried. In some areas, they're disposed of in the latrines. In other areas, flushed down the toilet. It all affects the environment in different ways. That said, like with all the information we do have, it looks as though the disposable menstrual pad appears to have the highest environmental impact, and that's due to the fossil fuel, the raw material, the energy used in those raw materials, and the amount of dry and wet waste that's produced. The menstrual cup appears to be the most strongly preferred from an environmental point of view, and that's even when sterilization occurs in a less efficient manner, and even when that cup is used for just 1 year. Important to note again, everyone's situation is different. So single-use pads disposable pads produced from locally sourced raw materials have a much lower environmental impact than an imported single-use pad and cost less. So we need to think about the context in which we're speaking. And the reusable pad is found to be the preferred option in India when you consider environmental impact alongside economic and social aspects. These are just a few stats to just underscore the amount of waste that we all produce. And 400 pounds of period product packaging thrown out. A single pad is, and this is talking about a store-made, a store-bought pad, the extra absorbent kind that has those kind of extra absorbent strips with it, and maybe even the wings that go underneath, and the sticky part of the pad that sticks to the underwear. That's equal to about 4 plastic bags per pad. We know, I mentioned the differing municipal waste management practices, and there's a lack of consensus around that. But if we look at in Europe and the United States, over 80% of those products, so the products and the packaging, end up in the landfills, where the plastics will take up to 800 years to break down, if they do that at all. And with the breakdown process, microplastics are produced, and those have been found all over, especially altering marine ecosystems, posing a big threat. They're one of the most common, the tampon applicators. I've been hard on the menstrual pad, but the tampon also is not a great thing for the environment with the plastic applicators. Those are found very commonly on the beaches.
And so thinking about these reusable options that we have, and of course these are studies done in people with uteruses, women, whereas we don't see the same research and robust options available to us as with so many things, right? So the idea of having a menstrual product like a cup or a disc is not available to everyone, nor is it a very advanced technological device, right? We haven't seen improvements in a very long time. So I think we're supposed to be happy we have it. So that's just one little thought on that. But they have been available for a long time and pretty much unchanged for a long time. There are 200 brands, probably globally. They hold, this is a tricky one. It's hard to know how much they hold exactly. I was actually reading a pretty fun study recently with my fellow where we were entertained by testing how much these cups can hold with packed red blood cells that weren't being used. So they probably hold up to 80 mLs, which is pretty cool, since that's when we can tell that's too much bleeding, right? It can be inserted for 12 hours. It definitely has a higher capacity than pads and tampons. They're costly, and depending on where you live, they may not even be accessible. And you really have to think about water. Do you have access to sanitation to clean it and replace it? Even within, like Dr. Harrison Megan said, even within just 1 year of using it, it saves a lot of money. And some studies are even showing with 6 months. So it can be used for up to 4 years, and I would say in many countries, this is a hot commodity. And I've talked to women who will come to America and grab a bunch of these and take them to their country and to home and to other clinics. And those people who may not have the same access will use these for far longer. I don't know the reliability or the leak factor if you get to use fewer pads, but they're nice and available options that do probably make a better impact on our environment. And we say probably because we just don't have enough robust data on this. Our own Sim Senden published this beautiful article in our JAMA Insights just describing how to place this little bugger. I think a lot of people, especially teens, are maybe not even advised about this, and it's sort of like our vaginal ring for contraception. We don't even give them a chance to have a choice, but I think we should talk about it. The vagina is a great place to use. We can have it for contraceptive devices, for menstrual cups. The vagina is not a bad repository to use in a useful way. It's discreet. And apparently now, right, great for the environment. So this is a really great image. It's also really popular. You know, about 75% of women in one study who've used menstrual cups are pretty darn happy with it. How many people in the audience have used menstrual cups or used them? Are you happy with them? Yay? Nay? Yeah, I mean, they work fine. They work great. So, I mean, I think it's just the awareness that they exist and that they're options and to give it a try. Certainly, we all have talked and used period underwear. I think this has sort of been more of our proponent of use for people who maybe have special needs or who don't want to use pads or who are young. And these can also be better for the environment, obviously because they're recycled, taking into account that they have to be washed. They're also made of synthetic, but some are now natural fibers. So that's another great consideration. And the other things to think about, as I kind of alluded to, is that you need to think about resources, water, privacy, pads, cost. There are, as I mentioned, there's reusable pads now being disseminated to areas where they don't have access to reusable anything. So that's really a nice consideration. Maybe areas to think about, you know, charity and public work that we aren't really addressing as a really common option to read a lot of really basic needs, because some people don't even know they're going to get their period, as we alluded to.
All right, so yes, this takes us back after hearing about some of those products that you can imagine how the use of those may mitigate some of the issues in that cycle that I talked about earlier. But a lot of barriers exist, just like everything else in medicine and advocacy. One of the largest barriers I think we have is research, right? So the research is up and coming and lots of people trying to do very good work. So it's not nothing, but it's scant still. And we need a lot more to be able to measure what the actual environmental impact is of the reusable products, so of the period underwear and the rest. The industry's lack of transparency around product composition and fabrication is a big issue. That makes it very hard to compare one pad to another pad, for example. So that's one thing we really need to advocate for, and consumers, put research aside, we do need to know what is in the products that we use, and I think we all deserve to know that and deserve to be able to tell our patients what's in those products. Never mind the environmental effects of them too. Lack of awareness. So for sure, this is something that I don't think is talked about very much. Given information about environmental impacts, we do know that some may choose to try the menstrual cup or another reusable product if they did know more about this. So something to keep in mind. Or natural fibers such as organic cotton versus others, which also has their issues. Cost is a major barrier for sure. There's a much higher upfront cost, and that can be a barrier certainly to people trying these things. There's a lot of evidence, however, that it's fairly cost effective over time. So purchasing a menstrual cup is about 5 to 7% the cost of disposable pads over someone's life cycle, if that ends up being something that they could use. Cost varies significantly from location to location too, which is an important thing to remember. Access. Now, this is something I could talk about for hours and hours. Access to products, so access to choice, access to all of these things. That's something that is a huge barrier, and we need to keep working on that. I don't know if anyone's from Scotland, but access. If you look up what Scotland's been doing, they're a real leader in the field, making these things available to people who need them. Making reusable pads locally in certain communities has been a real innovative change, so that's something else people could be looking into. Access to clean water, we've mentioned, is an important consideration. And product distribution challenges. So there's some menstrual product distribution policies and programs that have been put into place, and that generally has been helpful for some areas with product accessibility and affordability, but it's mostly focused on the disposable pad. So again, we need a little bit more transparency from industry as well to figure out, though, if they're the ones that are working with governments and other programs that are disseminating these products. Perhaps there's an inherent bias there that we need to keep in mind. And finally, stigma. That's a big one. So menstruation is still pretty taboo to talk about, and again, that's everywhere in the world. I think it happens maybe in some settings more than others, but not really when you think about how things are communicated in many areas. So we need really comprehensive, inclusive sexual and reproductive health education so that we can help everybody figure out what they need for them and get the local voice to be able to decide what's good for their communities.
So this is just a nice summary slide, just talking about things that we can do today, which is to raise awareness, really think about waste and resource allocation, and try to incentivize the use of items with sort of less materials, and looking to purchase those and put your energy into those personally and professionally. And I would just do a quick shout out, which is what I tell my patients a lot, is we don't have to be astronauts to not have periods. That's a great option. Don't have your period. We have very many safe ways now to suppress our periods effectively. It also happens to be great birth control, great for acne, great for PMS, great for Dr. Laufer's endometriosis. Like, hormonal birth control is magic in many, many ways, and also good for the environment, it turns out. And I joke about the astronaut study, but there's actually some really great data you may not know about in, what was the name of our journal? Now I can't remember. Oh, I forgot. It was like a cool journal, like an astronaut journal you probably don't read every day. But I was really excited about it because they can't go take tons of birth control pills onto their rocket, right? They need an IUD or an implant. And so just thinking about the role of these for people's lives that can improve them in different ways than we normally think about. And then the big option here that we all want and we all talk about, and is sort of my mantra in life, is choice. People need to know about periods. We need more research for people who have periods. We need industry to help support knowledge so we can educate and provide information to each other. We need to decrease costs. It's ridiculous, right? Periods are just what we do. Why is it so expensive and so impactful and detrimental? We need to have local voices, local sourcing, local leadership, local sustainability. This is like my little advocacy pitch. This is meaningful. This affects everyone with a uterus. It's something we all have to champion, and it's very basic. And we need to increase access for everyone who may not normally get access. So low-income countries, homeless shelters, jail systems, rural areas, all the places we all know very well in our local areas. And really be inclusive in teaching and providing access for all who menstruate. Thank you.
I'm glad to introduce our next speaker. This is Dr. Pallavi Lati. She's from Birmingham. She's in the executive committee of WCPAG, and she's a spokesperson for WCPAG.
Good afternoon, everybody. I'm now acutely aware that I'm encroaching on the lunch break, looks like, because we are running 10 minutes late. So, as I'm not going to tell you anything new, I'm just going to do a whistle-stop tour of how to deal with heavy menstrual bleeding. I have nothing to disclose in terms of conflict of interest. I am the current chair for the British Society of Pediatric Adolescent Gynecology. And I'd like to thank the organizing committee for having me speak on this topic. So the background is, we all know that the average age of menarche is 12 to 13 years of age, normal cycles 2 to 7 days, 21 to 45 days, and 60 to 80% of adolescents establish themselves into a regular rhythm by 3 years of menarche. Abnormal uterine bleeding is anything that is abnormal in duration, volume, frequency, and regularity. So if it lasts more than 7 days. And that forms the bread and butter of our pediatric adolescent gynae practice. So I really enjoyed the previous lecture on the impact on the environment, so all the more reason to reduce heavy menstrual bleeding, apart from the fact that it can affect quality of life quite significantly. So how do we establish whether a teenager is having heavy periods? Apart from the pediatric referrals that we get, that this child has become anemic, they were transfused 3 units of blood, please see them. We would have children who are soaking tampons or pads every hour, every 2 hours. They're flooding at night or passing large clots. Majority of the time, it's anovulatory in nature. But when teenagers present to us, it's important to remember about safeguarding, bullying, all those kind of issues that might be masked. Teenagers can lie. Sometimes they don't tell us that they might be pregnant. And I have had a couple of patients who have come with excessive bleeding, and only on when the bleeding is not settling down, we do scan, we have found retained products of conception. 10 to 20% of adolescents might have bleeding clotting disorders. And less commonly, you get teens with chronic illnesses who are on anticoagulants and so forth, who have menorrhagia, which needs to be contained. Important to avoid medical jargon and don't make any assumptions. So really, we need to delve into the details about the menstrual cycle. How frequently are the periods coming, how many days they are bleeding for, how many times they are changing their pads, and the context in terms of are they losing time of school, of the playground, is there any issues at school? Of course, family history is important, and sexual activity. Generally don't need to do much in the way of examination, apart from height, weight, blood pressure, and we need to only do pelvic examination if they are sexually active. Full blood count is a basic investigation, serum ferritin. If you have a child who is anemic, then you generally tend to run the bleeding clotting profiles. If they're sexually active, then STI screens. And only if you're suspecting other endocrine disorders, like if they are giving symptoms suggesting thyroid dysfunction or PCO, then you would run the rest of the hormonal profile. You put a hand on their belly, and if they do have mass, then you would arrange for a scan. But generally, for the first presentation of heavy menstrual bleeding, we wouldn't do a scan. We would just institute the initial treatments. So with the bleeding disorders, there is not much different in the way we treat them. Of course, liaise with the hematologist. Tranexamic acid works quite well. Combined pills work well. Only if they have got the bleeding disorders and they are undergoing surgery of some description, then you would have your hematologist tell you what to do, like give them DDAVP or tranexamic acid, things like that. Hormonal intrauterine systems seem to be a very good option for these teenagers. If the cycles are regular but heavy, then the tranexamic acid works quite well. If they are under 50 kilos of weight, then you give them 500 milligram 3 to 4 times a day for up to 4 days every cycle. In Britain, this is off license for under 12s, but I explained to the parents that it's been used for a very long time and it's a very safe medication to use. And majority of them are quite happy to use because they are only using it for 3 or 4 days a month. The NSAIDs tend to reduce the flow by up to 30%. So if your teenager has got dysmenorrhea and menorrhagia, then it tends to work well. Combination treatment, of course, works well because they are complementary and their mechanism of actions are different. Combined pill is extremely common first-line treatment. The first generation progesterone-containing pill seems to have low risk of VTE. So if you have an adolescent with limited mobility, then, and if you want to use a combined pill, you try and use the ones with the first generation progesterone. If they are less than 50 kilos in weight and are not able to tolerate the side effects like nausea, vomiting, and so on, then you can try a low-dose combined pill. Generally, I say to the teenagers that they can continue taking the pill, and if they get a bleed, they stop for 2 days and then carry on again. A lot of the times, tricycling seems to work quite well. As we discussed yesterday, there are contraindications, so migraines with aura. And it is really important to delve into the history of headaches, because a lot of the time the mother will say, oh, but she has got headaches or she has got migraine. And then I hope you all know what is the difference, what exactly is migraine with aura. Progesterone pill seems to work well in those with contraindications to the combined pill. And one of my colleagues in the UK did a small study where they showed that if you have got irregular bleeding quite a lot on the progesterone-only pill, asking the teenager to double up the dose for 2 or 3 months settles down the irregular bleeding nicely in a lot of teenagers. Then they can drop it down to single tablet. Medroxyprogesterone acetate tends to work well, but the problem is that they need to be taken more than once a day, so taking the tablets to school can be an issue with compliance. Norethisterone, in obese teenagers, you've got to be careful because of the bioconversion to estrogen. Implant, the amenorrhea rates are low, so they are not as good as Depo-Provera, but with Depo-Provera, I don't generally tend to use them in very young teenagers because of the risk of osteopenia. Yes, it is reversible, but a lot of them also don't want it because of the risk of weight gain, up to 5 to 10% risk of weight gain with Depo-Provera. Amenorrhea rates are quite high though. With levonorgestrel, we did a study at the Birmingham Women's Hospital, and we found that about 93% of our girls at 6 months were extremely happy after trying oral treatments and failed oral treatments. And there is about 5% chance that they might want to have the Mirena coil removed, especially the younger teenagers, because my theory is that their uteruses are not quite so well developed. So generally, if your uterus length is less than 6 centimeters, they are the ones who are more likely to have cramps. This is taken from the ACOG committee opinion on how to manage acute bleeding in teenagers. So the principles are you assess for anemia, anovulation, and presence of bleeding disorder. Examination includes doing the vitals, the orthostatic blood pressure measurements, pulse. Scan only if they don't respond to initial treatment. The first treatments, obviously, tranexamic acid, combined pills. Monophasic combined pills can be given 3 times a day for 3 days, twice a day for 2 days, and then carry on with once a day. Just be aware that with very high dose of estrogen, they might get nausea, vomiting as a side effect. I have only had to take one patient till date to the OR for EUA hysteroscopy and a Foley balloon tamponade. And this was an undiagnosed bleeding disorder. So this is very, very rare circumstance that we have to do a non-medical treatment. Once you get over the acute phase of bleeding, a lot of you must use norethisterone or medroxyprogesterone like progesterones in high dose and then wean them off slowly. The maintenance therapy is similar to what we have discussed before. I'm sure all of you have encountered parents with disabled teenagers who come asking for menstrual suppression. Some of them even come before the child has started periods. In that situation, I tell them to just wait until the first period is arrived and then discuss the options. But the reason that they might want menstrual suppression is some of them get exacerbation of seizures or hygiene is a big issue. In this situation, you have to discuss all the usual treatments that are available for menstrual suppression. Combined pills are good if your teenager is, quite mobile and not obese, extremely obese. If there is issues, then if they're having surgery for some other things like, children with chronic illnesses, then you might want to take that opportunity to fit a hormone coil under anesthetic. I have got a few patients who have this coil changed every 5 to 7 years and are very, very happy. If they have PMS symptoms, then ovulation suppression seems like the way to go. And I'm not sure how many of you have used GnRH analogs with add-back HRT for menstrual suppression. Raise of hands, those who have had to use. Yeah, so there is some experience. Very occasional patient you will get. I have had one patient who has resistant seizures, and the mother wanted this child to have a hysterectomy. She was a very extremely disabled child with cerebral palsy, wheelchair bound. And in the end, we settled on GNRH analogs with ADVAC HRT, and 7 years later, she still continues on it. So we had to take second and third opinions from other PAC specialists and then agree on this. So, in summary, for heavy periods, you evaluate for anemia on ovulation and presence of a bleeding disorder. Scan if you don't have response to initial treatments. If your the cycles are regular, then mefenamic tranexamic acid works well. A lot of parents, especially younger teenagers, might be very reluctant to start on the hormonal contraceptives. So you can reassure, especially if the worry is about final height, etc., that the pills are low-dose estrogen-containing pills, and most of the height is achieved anyways by menarche. On the BRITSPAC website, we have got information leaflets, which we use quite regularly, but you might have similar leaflets across board. I'd like to thank you and say enjoy your lunch.
Now I want to introduce someone who doesn't have to be introduced. You already know her. She's Dr. Judith Simsendan, and she's a current treasurer of the Fiji and president of NASPAC, and she comes from University of Central Florida.
Miami now. Thank you so much, and thank you for the kind introduction, Daniela, and what an honor it is to be here today. I'm going to be speaking about Fiji's document, Menstrual Health Globally, that was a combined effort by the Fiji Advocacy Committee. First of all, props to the Fiji board and Paul Wood, and for the huge support that we've had for developing an advocacy committee in Fiji. Fiji has really grown as a society, and it is doing wonderful work in education. You'll hear more about the bursaries, and then advocacy, which is just tremendous. This document was developed with the Advocacy Committee. I co-chaired with Evelyn Rose, and then Angela Aguilar, Mariela Ortiz, Clara Denuncio, and Anastasia Vatapolo. But we've also had wonderful support from Emily Gelson, and Makilena, I'll say it wrong, Drevcha, who's now at the UK. The document that I'm going to present has been endorsed by FIGO, by the Royal College of OBGYN, and other societies as well. I have no disclosures at this time. So I'm going to start actually with the end of the document, which is the call to action. This is a call to action document. In our call is to integrate scientific, gender-sensitive health education in school curricula, to encourage appropriate management of disabling menstrual symptoms such as heavy bleeding and severe pain so that girls can stay in school and have improved quality of life, to support legislation and initiatives to provide funding for basic necessities such as clean water and private sanitary facilities to improve menstrual hygiene among adolescents, and to advocate for a revisiting of cultural norms to end discriminatory and stigmatizing beliefs and practices surrounding menstruation that limit female adolescents from realizing their full potential in society. And yes, I use the word female. There have been calls to use the word individuals who menstruate. I still like using the words female and women because I think that that's a huge part of who we serve. But when I speak about these, I do want to be inclusive of transgender individuals and anybody else who menstruates. So first, I do think we need to advocate for comprehensive reproductive health education to help reduce unintended pregnancy and STIs. Yet this remains politically charged even in my own state. Why are we having to do this still? Menstruation, as we all know, as Dr. Tyson and Dr. Harrison mentioned, it's a physiologic process that half the planet experiences, and we menstruate for 40 years. It's been mentioned, it's not news, in the Old Testament, in ancient Greek writings, and in Egyptian hieroglyphics, probably as much as any place else. Menses is the month in Latin, it's Mene is the moon in Greek. So why are we still having to advocate for menstrual health education? I think it's really important because now we've been outpaced by social media. This is the main source of sexual and reproductive health for adolescents. There are 1 billion TikTok monthly users worldwide. Try getting that kind of access in the schools, right? There are 80 million monthly active users in the United States, of which 32% are between the ages of 10 to 19, 74 million active users in Brazil. I mean, this is just global. Why is it so popular? Because it's easy to use and search. It's easy to create videos. The videos are short. All of us have a short attention span, and it's easy to customize and monetize. Social media algorithms present content that is popular, not necessarily correct. So if you are more dramatic, oh my God, I'm dying from my birth control, then you're gonna get a lot more likes. If you look at the a search, this was presented at the American Academy of Pediatrics, there are about 148 TikTok videos about birth control adverse effects. 84% were created by lay people and had about 140 million views. 3.4% were by licensed healthcare professionals and had about 14.5 million views. We are less interesting. Okay? It just is. There are so many common menstrual myths that are still out there. If the blood is dark, it's dirty. I see this all the time. If she bleeds less, she will not be cleaned out. All right? We've all in the room heard this. Heavy periods are normal in my family, so they're normal for me. My mother had a hysterectomy at 20. My aunt had a hysterectomy at a young age for heavy bleed. They're just normal. And using tampons will cause her to lose her virginity, want to have sex, develop infections, get cancer, be infertile. I mean, these are universal phenomena, and I wish I could tell you in the United States it's any different, pero vivo en Miami. It's a huge problem here in where I live in Miami as well. Meanwhile, comprehensive, evidence-based reproductive health is considered a political issue. Recent legislation in Florida has restricted any discussion of gender-based education below elementary school level. It's really very challenging. And as was mentioned yesterday, I think this is really important. We need to have the language to fight back. Politicians use parental rights as the rallying cry to restrict sexual health education. And it's very hard to argue against parental rights. So we need to have our own language. Adolescent rights are less compelling. It just is that way. And parents can vote. So we have to be careful on how we use language and how we involve ourselves in these processes. There is a wonderful document put out by the World Health Organization, The Journey Towards Comprehensive Sexual Health Education, a global status report, where it talked about good quality comprehensive sex education that is scientifically accurate, incremental, age and developmentally appropriate, curriculum-based, based on human rights approach, based on gender equality, culturally relevant and context appropriate, transformative, and able to help individuals develop life skills needed to support healthy choices. Here's some vocabulary to use as you advocate. Now, we're all in medicine here, and we're all scientists, so we think that this should all be intuitively obvious, right? Well, with the rise of the internet, and we've all seen in our own countries, people who come up with these crazy ideas that validate them from the internet, and we've lost credibility. Both our CDC, World Health, people don't take as seriously, especially in certain degrees of politics, the importance and weight of science. We have got to get out there and bring this back and advocate for science. We also need to advocate for improved management of menstrual disorders to improve the health of adolescents. We had fabulous talks already on endometriosis and dysmenorrhea today. These were excellent, and heavy menstrual bleeding. But we need to take it outside of our own societies. We need to become an educator, sorry, the extra typo, for our colleagues and our trainees. We need to be in the pediatric space. We need to be in family medicine, nurse practitioners, other physician extenders, community health educators. We need to reach out beyond ourselves as educators. Many of these people receive very little education in pediatric gynecology in their training or their continuing medical education. Getting out into the medical school curriculum, because sometimes PAG is seen as high-end specialty, It is so key. And you'll find a young near-peer group of medical students who are passionate about PAG when they learn about it. This is really important. And as a little self-help, educating our colleagues improves not only care for our patients, but it improves your own referral base. And if you're a young PAG provider and new in IFA-PAG, the more you get out there into your community, the more referrals we get, the bigger our practices get, and the more we can build our research bases as well, because we have more robust practices. We do need to advocate for the elimination of menstrual poverty and stigma related to menses to improve the social determinants of adolescent health. And we've heard a lot about the environment and menstrual poverty. There are still so many myths that persist, that menstruation is dirty and shameful. This can lead to restriction of access to religious spaces, school, extracurricular activities, and social gatherings, making women less able to participate in public life. And also, menstruation is a false marker for maturity, that as soon as you menstruate, you're eligible for marriage in some societies. So this is so important. Recently, in my own state, in this last year, the Florida High School Athletic Association tried to pass requirements that female athletes report their menstrual history, their age of menarche, their regularity, when their last menstrual period was. The data was to be submitted to athletic coaches, not just doctors. And thank goodness a whole cadre of physicians came out. We got on the news, we got on social media to express concern about privacy, bias in allowing girls to play, even putting girls at risk for sexual abuse if the coach knew when she probably couldn't conceive. I mean, I hate to say that. It's awful to think about, but it's important while we make awareness about menstrual history that we also protect the privacy of our teens. All right. We need to advocate for improved management of menstrual disorders to improve the health of families for generations. There's a whole theory out there called the life course theory that talks about how important a woman's exposures are before she becomes pregnant, during her pregnancy, and then afterwards, that affects the health of generations. Pregnancy can now be seen as a continuum or a trajectory of health rather than a detached stage of development. Birth outcomes may be affected by maternal development across the lifespan prior to pregnancy. Through comprehensive evidence-based education, recognition and management of menstrual disorders, reduction of period poverty and shame around periods, we create healthier adolescents leading to healthier pregnancies, healthier babies, and again, healthier generations. So what can you do? Work with your national societies. Get them to adopt the Fiji advocacy statements or write your own if it's more relevant for you. Provide education to medical students as well as faculty and residents in peds and OB and family and wherever they'll let you talk. Go out there, especially places where they don't have a lot of training in PAG. Harness social media, but carefully, very carefully. And honestly, support politicians that support reproductive health care for adolescents and vote. Thank you.